Thank you, Dr. Bennett, for that detailed, comprehensive appraisal of the guideline. I think it's also tried to address a lot of these issues regarding what will be the standard of care for any patients.
Yeah.
All the queries which we do address, meaning we come across in clinical practice, like
Sir.
how far should we go with assisted feeding,
Yes, sir.
assisted ventilation, use of drugs like
Yes.
Riluzole, Edrovon, which are costly and meaning it's
Yes,
difficult
sir.
in resource limited constraints, as well as other novel experimental strategies
Yeah.
which people do outside off label like
Yes.
stem cell. So that is one of the advantages of this guideline,
Guideline.
as you rightly mentioned. Thank
Thank
you.
you, sir.
we'll have a brief Q&A. I'll just request, because there were many speakers, that when you're answering, if you can stand in front of the camera there. Here, that may be the easiest. And first and foremost, I think we need to give a big applause to the Department of Neurology and all the very innovative work. And though I'm not looking like it, but my mouth is hanging open, and I'm quite amazed and impressed by the variety of skills. And I'd also like to congratulate Dr. Sanjit on his landmark trial, which has been recognized worldwide. The questions, I will go the other way. There are a lot of questions for Dr. Sanjit, so we'll end with him. But I will first start with Dr. Vivek. Dr. Vivek, the mic is. So just if there are any questions from the audience, please add on. There's none here, so I'm going ahead. I've been given license, so I will. So, sir, you ended with the pragmatic slide of the breakthrough. No, why do seizures actually occur? Which is the most common reasons why patients come to you in OPD with breakthrough, and what's advice for us as practitioners?
Um, Breakthrough seizures, most commonly, of course, is compliance, or it could be because of some intercurrent medications that they use for some illness. Uh, these are the most common causes. The other thing could be that they had a provoking factor which is not addressed, not counseled adequately, probably some sleep deprivation in certain situations. So there are some epilepsies, for example, the juvenile myoclonic epilepsy is very sensitive to sleep. So if they sleep inadequately, the chances of having a myoclonus at least the next morning is quite high. So these are the common causes for breakthroughs.
Dr. Vivek, just one more question for the devices. How effective and what is the cost? What's the experience in,
Yeah, so these devices so as we go in epilepsy upwards in epilepsy treatment, we have definitive. So we're talking right now only about drug refractory epilepsy. So in which is a small but important percentage. The drug refractory epilepsy we can think of in their treatment as two possible avenues that we can walk down. One is there where we can offer them a definitive surgery for cessation of seizures. So the best model for that is somebody with a mesial temporal sclerosis, where we do an anterior temporal lobectomy with amygdalohippocapectomy. If we have a good, well lateralized, good localized seizures, and the patient does well, we can offer them that 70% of them will come off medications for long term. It's a very simple surgery to do. And unfortunately, what I was trying to tell you about the epilepsy treatment gap, we have patients on follow-up who are refusing the surgery even now as well, despite multiple sessions of counseling, even if we offer them free of cost. That's one. That's the pathway for definitive surgery. The other pathway is palliative, where where the seizures are coming from eloquent areas and cannot be removed, or it's a large epilepsy circuit. So this is the group that we are trying to address by all these devices, various ways of looking at it, and the availability is gradually increasing. Responsive neurostimulation, DBS, the vagal nerve stimulation, these are all, as of now, have been very expensive, but non-invasive approaches are also coming in, and there is a possibility that these things in the next few years itself we'll be seeing a major expansion in our options available for palliative approaches. So the palliative approaches that we use right now are ketogenic diet, corpus callosotomy. These are the ones that we use for bringing down certain aspects of seizures or bring down the burden of seizures, even if you're not able to cure them of the epilepsy.
Thank you so much, Dr. Vivek. To the audience, you have to go from perception to action, to quote Prabhakar. So if there are any questions, please put it online. I'll request Dr. Ajit to please come forward. I think the question that I wanted to ask was for chemical plex, which are the group of patients that you would advise us as practitioners? Where should we look out?
Yeah, it's mainly for antibody-mediated diseases in neurology will be mainly myasthenia gravis and CIDP, myasthenia gravis especially. But it has hematological indications also. Other spectrum of medicines also can be there. So these are patients who require like maintenance intravenous immunoglobulin infusions or maintenance plasma exchange. This a subgroup of patients, very rare, maybe less than 10, who might require monthly plasma exchanges, monthly injections of intravenous immunoglobulin, are not responsive to the usual, are intolerant to steroids or other immunosuppression. So this doesn't cause much hypogammaglobulinemia. And now with more targeting of the specific antibodies, what is being mentioned is that they can be just given as monthly infusions, what has been done in trials. And trials have tested up to 12 to 18 months of treatment and found that the disease severity scores also reduce without an increase in any infection risk.
And the second question would be, you did mention that most of our gene therapies are very
Yes,
costly.
yes.
You said there is something called easy access. I'm not.
Early access
Early
and
and-
expanded access programs, which right now it is in two ways. One is the pharmaceutical companies are ordering, and the other was NGO-based organ. Like we would have seen in Facebook and other social media, like just like like we used to see for hematological disorders and stem cell transplant, like this such child has spinal muscular atrophy, kindly support. So in which case they tend to go for crowdfunding campaigns and able to generate quite a lot of money, especially in infants and all. It's quite helpful, especially with the adenovirus vector therapy, because it's almost a single therapy. Almost the gene gets replaced. For the other drugs like nusinersen, in which you need to give a continuous infusion followed by once a month dosing, which is less expensive compared to the gene replacement. There also, it's been tried almost, I think there are more than 35 children in India who have got access to these therapies. This is still last year. The oral medication also through social media crowdfunding campaigning, the Risdiplam, which is come into the market by, which has been manufactured by Roche company right now. The 6-month cost of therapy for 6 months is around 72 lakhs. And the company gives deals like if you buy for 2 months, we'll give 4 months extra. So there are actually a lot of people, including in Chennai, who have access to these therapies with assistance from their companies and from NGO organizations.
That's really good to hear, because when the pharma company steps
Yes,
up, then
yes.
especially for children, it's good.
Yeah.
I don't think there's any other. Is there any other question? Yeah, thank you, Dr. Raj. I'll just like to call Dr. Prabhakar, please, for 2 questions. Just to, in terms of imaging advice for Alzheimer's, would you suggest to us that would a PET brain be our first line instead of going stepwise from an MRI? What was the suggestion?
Very often MRI and history is more than enough to make a diagnosis. A normal looking MRI with a typical history is enough. And advanced PET imaging is useful when diagnosis is in doubt or if you're planning any interventions. And also now there are all volumetric analysis and AI-based tools that are available that can look at volumetry of the MRI and then give predictions of whether AD is possible or not.
And for the I'm assuming the Veloc ECOG has been validated, is it?
It's been validated, waiting to get published.
Waiting to get published. So I was just, that was the next question, saying how can we all access and, even.
So we are trying to make it available on a website. Right now it's done within the department. So once it's there as a website, then it can be accessed.
Thank you, because sometimes we struggle with specific scales for our population. So thank you so much, Prabhakar.
Thank you.
I just request Atif to please come forward. Hi, Atif. Just to ask about the alpha-synuclein RTSA, which
RT-QuIC assay.
RT-QuIC. Somewhere along the line, anyway, it doesn't matter. So please, you said it's going to be available soon, or it is
Yes.
available. Which is the tissue you said would be better for it?
So
Skin or
in skin and CSF, we have good results. Skin is the best, but we're trying to improve CSF better, because skin you have to still take a punch biopsy. It's just a 4 biopsy. Right now we are doing it from 2 sites, but one should be enough eventually.
Okay. So, and thank you for that. So the other thing is, when you said among the therapeutic options, these were the diagnostic, which would be the best right now? I know you mentioned a lot of the newer ones. Which do you think has the most potential?
So the newer ones deal mostly with advanced Parkinson's, because for initial, usually levodopa carbidopa is more than enough. Deep brain stimulation, of course, if the patient is affording, as of now, and it's available. Uh, I have not seen a patient with a continuous levodopa infusion, but apomorphine used to have a lot of problems. So the levodopa, whoever has used, have spoken to one or two of them, and they are coming in a lot of awe. So levodopa infusion, so it holds a lot of promise. It's yet to come in India, but
And I think we all have to develop a keen sense of smell.
Smell.
Maybe when it comes to diagnosis of PD, it would help. So thank you, Dr. Atif, and I will just hand over to Dr. Sanjit. He will answer some of the questions he's got.
So, first one is, what is the medication of choice for acute blood pressure reduction in stroke? So, best thing is labetalol. So we can give it in small boluses till we achieve the target. The more important is which medication you should not be using. One is nitrates, which will cause vasodilatation and further increase your ICP, and also diuretics should not be used because that will reduce sodium and cause, again, it will contribute to your brain edema. How do we decide between dual and single antiplatelet therapy for posterior circulation stroke? So anybody with a large artery occlusion, it is all dual therapy for at least for first 3 months. We are just conducting a trial looking at continuing dual therapy beyond 3 months. That trial will be getting published maybe next year. If it is a lacunar infarct, then it is only single antiplatelet agent. Is there a role for anticoagulation in isolated cortical vein thrombosis? Yes. So anybody with cortical vein thrombosis, we have to follow up with anticoagulation, either NOACs or warfarin. Again, we are involved in an international trial looking at NOACs versus warfarin, which also will get published soon. What is the role of anticoagulation in thrombotic strokes? This is very simple. Any cardioembolic stroke, you have to anticoagulate. Also, sometimes we get patients with a carotid stroke with a floating thrombus. Again, we'll have to anticoagulate. What do you think we can take good stroke management to rural and remote parts of India where stroke is common? So here, I think we are looking at three things. One is acute management. For acute management, now the Indian Stroke Association is setting up something called stroke ready hospitals and comprehensive stroke centers. So stroke ready hospital will be where they can actually thrombolize. They just need a CT scan and thrombolize the patient and then shift to the comprehensive stroke center where other treatment can be given. And second, most important here, I think in a rural and remote part, it depends on which part of India, because studies have shown that as you go towards the east, the hemorrhagic stroke is more. Probably due to some genetic cause, like in Assam and beyond that, it is very high incidence of hemorrhagic stroke. Even in, it doesn't matter whether the hypertension or not. It's not related to hypertension. So in fact, our department is involved in 2-3 trials from the Northeast, looking at any genetic cause for this. So it depends on which rural part you are, and then you have to take particular precautions in that area to identify what type of stroke is prevalent and then take precautions as a primary prevention. And secondary prevention, of course, should be done. Rehab, I think this is a very interesting thing. Right now, neurology department and bioengineering department and also PMR, we had got a huge ICMR grant where we have developed low-cost semi-robotic rehab, which actually you can take it to the village and use it. This is a trial which we have started, also involving IIT Chennai. So next question is, when should we start triptans in migraine patients? Criteria to decide that. So triptans will be a good choice for any young migrainer, provided they don't have three things. One is hypertension. Second thing is migraine with brainstem aura and hemiplegic migraine, which is rare. So, but avoid using it in elderly patients. They may be having a unrecognized ischemic heart disease. Can you provide evidence of local installation in headache? Yeah. So local installation there's no controlled trials for that. It is only used in acute settings where you are desperate to give the patient relief, especially in acute episodes of cluster headache. How many years can we start antiplatelets in a CVA bleed? So there is a trial you can look up called the RESTART trial, which looks at restarting antiplatelets in patients with hemorrhagic stroke. In fact, this trial showed that those patients who get started on antiplatelets does much better. They have not only lower incidence of ischemic stroke and hemorrhagic stroke. So definitely we can restart it within the first 1 month if there is no, the hematoma is stabilized. What will be the cost of the Nervio device? So it costs around 16,000, but we had with the company, we had an agreement to CMC, they are giving it a cheaper rate, around 12,000 rupees, and we can even negotiate and bring it down further. And for CMC staff, I think they have a special rate. It's not covered by staff student. What that thing? Okay. Yeah, that's what I'm saying. It is around 15. So.
And there's one question here. Which patient should be DBS for? Is it effective more in young PD?
So DBS, there are, it is usually for advanced PD to be done at least 5 years of diagnosis, and patients who require more than 5 times dosing of Syndopa, levodopa, or they have more than 1 hour of troublesome dyskinesias which do not go despite adequate drug adjustment. In young patients, the same criteria is used, but we may use it a little bit earlier because then they have a longer period of uh, uh, low disability. So they'll be able to work better and things like that better.
Thank you, Atif. There's just one more question for Dr. Sanjit. Can we thrombolize if NIHS's score is less than 4?
Yeah, so earlier there was no evidence for this. We are thrombolizing NHS of 4 who comes early. But right now, both the American guidelines and the European stroke guidelines says there's more risk of hemorrhage with the lower NIHS. But if the NIHS scores for, say, aphasia or like a visual impairment or something, then we can still go ahead and thrombolize.
So this will be the end of the neurology session. Thank you for all your attention. There is tea available, coffee break after this. And thank you again.
For the audience, we have your Kahoot quiz ready for the neurology session. If you would all please log on to Kahoot.